Thanks again, Deborah, and hello all. Really pleased to be with you this morning. So again, my talk will briefly review the Los Angeles Barbershop blood pressure study of which I was a part, and I've sort of framed this as a case study of how we can better engage older minority adults in research through community-based initiatives. So I'm sure many of us are aware minorities continue to be underrepresented, in most clinical trials, despite ongoing efforts to address this challenge. Even legislative action like the NIH's Revitalization Act of 1993 have failed to have sort of the desired impact, lasting impact on minority accrual that was hoped for. This lopsided participation rates between whites and other racial minorities is particularly troubling in disease states that disproportionately affect these groups. I won't spend too much time talking about this because we've sort of, reviewed and sort of rehashed sort of the barriers to engagement, but I'll try to be brief here, but I like to think about it in terms of three categories. The first being approachability, which includes awareness, a perception of need, or the knowledge of the disease state and its associated risk. Acceptability, which encompasses issues around trust, and cultural competence, which are particularly relevant for minority groups. And then finally, accessibility, which we've talked quite a bit about, transportation, time, and financial considerations. So if thoughtfully designed, community-based initiatives have the potential to directly address these three A's, if you will, and improve engagement. Given that these interventions are often carried out in secular venues that draw sizable and diverse crowds, the visibility alone has the ability to increase awareness amongst the community and the entire community as a whole, not just those at the research targets. Community-based obviously implies that we're meeting people where they are, which increases accessibility. And finally, these studies often can call upon community members or trusted individuals that can help deliver the intervention, which helps increase acceptability. Venues for community-based outreach have included fairs, community centers, senior centers, and more commonly churches, but regular church attendance among Black men specifically is lower than Black women. There is a long history of barbershop health outreach in the United States. It dates back to the 1980s, but the barber medicine connection dates back all the way to the Middle Ages with the history of barber surgeons. And for those of you who are unfamiliar, barbers in those ages were allowed to perform, small medical procedures like bloodletting, cupping, tooth extractions. So they are often regarded as, trusted, respected members of the Black community. In interviews that I've had with participants in the Los Angeles barbershop study, some would say that they'll tell their barber things that they wouldn't even tell their priest or spiritual advisor. So these are important relationships. They're long-lasting relationships, which is perhaps unsurprising because the average Black man goes to the barbershop weekly or bi-weekly. The laid back and comfortable environment that the barbershop creates, a place for information exchange and a relaying of shared experiences. So an ideal venue for reaching out to Black men. With these attributes in mind, the principal investigator of the Los Angeles Barbershop blood pressure study set about to design a barbershop-based pharmacist-led hypertension trial that sought to address racial disparities in hypertension. And I know we've been asked not to share too much disease-specific information, but just as a little bit of background, the prevalence of hypertension amongst Blacks increased to about 55% with the release of the new ACC-AHA hypertension guidelines. Black men have less physician interaction than Black women and thus lower rates of treatment and control. And this directly contributes to their having the highest hypertension-related death rate of all racial, ethnic, and sex groups in the United States. So the aim of the Los Angeles Barbershop blood pressure study was to develop an effective and convenient blood pressure intervention for Black men, which links health promotion by barbers to drug therapy by pharmacists. So we randomized Black male patrons of Black-owned barbershops with uncontrolled hypertension by barbershop to either an intervention group in which barbers promoted follow-up with Pharmacist, or to a control group, which was essentially usual care. In the intervention group, the Pharmacist met with patrons at least monthly in their own barbershops, where they checked blood pressure, prescribed medication under a collaborative practice agreement with the participants' primary care physician, and then they also monitored electrolytes. Depicted here at the bottom of the slide is sort of a depiction of what our treatment model is. So the rectangle represents the barbershop environment. So barbers referring to pharmacists and pharmacists treating patrons. And then there were external relationships with both community pharmacy and then community providers as well. The pre-specified outcome was the change in systolic blood pressure at 6 months. And this was really a measure of efficacy. And then the change in systolic blood pressure at 12 months as a measure of sustainability. So men aged 35 to 79 were recruited from Black-owned barbershops in LA County over the course of about 2 years. We spent anywhere between 4 and 6 weeks in each shop. And we recruited men who had systolic blood pressure greater than 140 millimeters of mercury on 2 separate days. They also had to be regular patrons of the shop, which was important for increasing retention. So research personnel staffed the barbershop at all hours of the day, all days a week, if that was how many days the shop was in operation, and offered free blood pressure screening to everyone who walked the door, regardless of eligibility. And we felt this was really important, both to increase awareness about hypertension in the community, and also to foster sort of this trust or goodwill. And then finally, a research registry was established for future studies, and anyone was encouraged to apply, even if they were not eligible for this particular trial. So again, over the course of about 2 years, a little over 4,500 people were screened in just over 50 LA County barbershops. Ultimately, 310 were enrolled. At 6 months, we had 95% cohort retention, and at 12 months, we had 90% cohort retention. As you can see from this flow chart here, the primary exclusion of participants was due to them not meeting the blood pressure thresholds for eligibility. And I will say, of note, 3,000 of the 4,500 that were screened agreed to be part of a research registry, which we've already gone back to tap for future follow-up studies.
We have 2 minutes left, Chantel.
Okay, great. So Steve Chen touched on this yesterday. The average age of the folks participating in our study was about 10 years younger than the group that we're targeting here today, or we're discussing here today. But there were 18% of the cohort was over the age of 65. I'll make just a very quick point here, and I think, again, Dr. Chen made this point yesterday. The average barbershop was in business for 17 to 18 years, which is an extraordinary long time for any business in Los Angeles. And the reason being was that the average man in our study went to the same barber every 2 weeks for about a decade. So this really drives home the point that the barbershop is a highly frequented social hub for Black men and a great place to treat a chronic condition like hypertension. Just because I'm a little short on time, I won't take too much time reviewing this. We did create role model stories or peer experience stories, and these were basically generated from brief interviews that we took with participants to the study. We created posters and hung these in the barbershops, and the idea was that we would both educate other patrons and encourage participation. So these are just two quick, brief stories about older adults who participated in the barbershop study. Ultimately, LA Barbershop was an enormously successful trial. We saw a 21 millimeter greater fall in systolic blood pressure among intervention participants when compared with the control group. The high retention rate obviously was remarkable, but what really have we learned? I think it's fair to say that barbershops can be convenient and effective hubs for the recruitment and retainment of Black men and older Black men in clinical research. Community-based initiatives that are designed to directly address the common barriers to engagement can increase minority participation and participation of older adults. So LA Barbershop was an accessible model that clearly met people where they were. And for older adults who are often less mobile, this can be particularly important. Barber endorsement helped to overcome issues of mistrust of the medical community, and frequent patronage helped facilitate frequent follow-up. So Los Angeles Barbershop was really an intervention that was tailor-made for Black men. And I think tailoring interventions to specific underrepresented groups can help improve engagement. More research is warranted to determine what these venues would be for other groups. For Black women, beauty shops have been put forth as a potential location, but more work is needed to figure out what this would look like for Hispanic men and women, Asian men and women, Native American men and women, and I'll leave it there.